everyone, and welcome to OE Headlines, a new podcast show brought to you by the team at Ortho Evidence. My name's Abby Payne, and joining me in studio today is Dr. Mohit Bandari, who's our editor-in-chief at Ortho Evidence, and Dr. Brad Petrozor, trauma surgeon and professor of surgery at McMaster University. Mo, Brad, welcome.
Welcome. You know, why does Brad sound so official? Like professor. Well, that's nice, Brad. That's nice. I'd like to get that title one day.
Distinguished professor.
Distinguished professor. Yes. So let me start off first by saying thank you to everybody with sincerity from our group for taking a look at our first episode. I think we had exceeded our expectations, and we really appreciate that you were listening. We also appreciate that some of you took the time to write us a note and particularly give us some new insights and questions that we can tackle. If you have some ideas after listening to this one, please do not be shy to email us at headlines@myorthoevidence.com. That's headlines@myorthoevidence.com. All right, Abby, back to you.
So we're going to kick off today's show, as usual, by first addressing our OE headliner story. Following that, we'll dive deep into the Fast 5 stories that are trending within the orthopedic community today. A new BMJ article was just published, and it questions the clinical value of some of the most common orthopedic procedures. The study found low to moderate quality evidence indicating that these procedures aren't necessarily superior to non-operative care. So we'll put on screen now a list of these top 10 procedures that are currently under scrutiny. But today we're going to be focusing specifically on one procedure in particular, and that is total knee arthroplasty. And joining us today via video chat is, to give his expert opinion, is Dr. Emil Šemić, who's a joint reconstruction surgeon and chair of the Department of Surgery at Western University. Emil, welcome.
Hey, Emil, I just wanted to say that Abby referred to you as a professor and chair, just like Brad, and I didn't get the title professor and chair. So I'll let you know. The hierarchy that's here. But anyways, how you doing, Emil? Thanks so much for joining us.
Pretty well. And pleased to be here.
That's great. So did you want to go on, Abby, with a bit of an intro? Okay.
Yeah, I will. Before we dive into this, what I'm sure will be a very insightful conversation, I will give you a bit of a background. So the article suggests that the evidence base for recommendations on total knee replacement was built wholly on observational retrospective studies that have often used prosthesis survival as the primary outcome measure. However, this guidance is now supported by one RCT published in 2015. So even though 7 of these procedures, including total knee arthroplasty, have been recommended for use by national guidelines, a high-quality body of evidence on the clinical effectiveness to support these recommendations currently does not exist. So Mo, what are your thoughts?
Well, it's very interesting, and I would like to get your thoughts on this too, Emil, which is, it's incredible to see operative versus non-operative treatment, I guess under scrutiny to some degree. Now, there are some of the recommendations that I think you'd agree with, sort of the arthroscopic lavage, degenerative arthritis. But I found it particularly interesting that even total hip arthroplasty or lack of evidence for total hip arthroplasty has come under some scrutiny. Do you think, and I guess from your perspective, that a randomized trial of total hip arthroplasty versus non-operative treatment is somehow going to change practice at this point? Or even before you get there, let me ask you the other thing to think about is, do we even need an RCT at this point on and areas like total hip arthroplasty related to its value compared to non-operative treatment?
Well, I think you bring up a really good question. I think at the end of the day, one of the things that I find that's problematic with this article is the notion that somehow the presence or absence of an RCT really equals the presence or absence of clinical effectiveness of a procedure. So in essence, basically, the article suggests that because there is no RCT that supports the use of total hip arthroplasty, you would then conclude that there's not really, evidence of clinical effectiveness of the procedure. And I think that logic is really flawed. And there's no question at the top of the evidence pyramid sits the RCT. But you can draw like a lot of conclusions and make a lot of inferences from, high quality observational data. And there is tons of it with respect to total hip arthroplasty. There's a tremendous amount of information that shows that a very high percentage of patients, more than 95% would benefit from having a, hip replacement, would benefit in terms of pain relief, improvement in function, improvement in quality of life. There's all kinds of PROMS data, which shows that various outcome tools show clinical effectiveness. There's cost effectiveness data that shows that the hip replacement is effective, and really begs the question, if you are certain about the effectiveness of a treatment, should you really be doing an RCT if you don't have one? I would say the answer to that question is no, you wouldn't do an RCT. Like if you know the answer to the question and there's no uncertainty around the treatment, why would you consider looking at doing an RCT?
Well, it gets back to equipoise, right? The whole issue that there's truly uncertainty. And what you've said is, nah, not anymore, there isn't, right? For sure there isn't anymore in this area. Well, let me ask you this. So the authors go and they write, given the current waiting lists for surgery due to COVID-19 pandemic, a randomized control trial comparing total hip replacement with best non-surgical care may be both timely and prudent, especially if those patients randomized to non-operative care are subsequently offered surgery, should they be dissatisfied with the outcome of non-operative care. The argument here almost seems like patients are going to be dissatisfied with non-operative care and ultimately end up in a hip arthroplasty. But do you think that trial right now is a reasonable offering, given what we know about total hip arthroplasty?
I don't think it is, because I think at the end of the day, you don't have equipoise, and most patients presumably on a waiting list have exhausted conservative treatment. And I mean, the natural history of severe end-stage arthritis is to deteriorate over time. I mean, there's some ups and downs, some fluctuations, but the bottom line is, if you wait 12 or 18 months, you're going to be substantially worse. And some patients potentially, if they're losing bone or deformity is increasing, actually come to harm by waiting. So I really don't think there is a role for that RCT. The evidence is just so overwhelming in favor of surgery in this area. I don't see how these conclusions can be drawn.
And I think I'll also state, Emil, and I don't know what you think about this too, Brad, but the issue that just because a randomized clinical trial suggests no difference, means that there's truly no difference, right? I mean, there are lots of situations where you could have a false negative finding, right? In that a no difference could actually be a difference. We just don't have a big enough sample size, and it's just not appropriately powered. The majority of the studies that have been done are fairly small, right, in this review, that you have to also look at the quality of the trial itself. I'm not saying, obviously, doing a trial is really hard, and it's complicated and it's difficult, but I think we also have to make the assumption that small trials are dangerous because they're believed, and we have to be really, really cognizant of feeling that that the evidence is robust enough for either showing a difference or not. And I think that part of that story is really important.
Yeah, I agree. If I could just jump in.
Okay, go ahead. Go ahead.
No, I was just going to say, I think, one of the other issues with doing an RCT like that, I think, at the end of the day, if you've decided you're going to have surgery, recruiting patients into a trial like that, I think is going to be a challenge. And then you wonder, if you're recruiting, 1 out of 10 patients, for example, into a trial like that, like what is the selection bias around that 10% of patients that you're recruiting? And is that really representative of all patients that are on a wait list for surgery?
Yeah, well, I certainly offer all the hope that those who wrote this article and are suggesting that this trial be done are able to, in fact, execute on that promise, because that'd be interesting to see if they can do it. But there are going to be some real meaningful challenges. Brad, you had something you want to say?
No, I just keep thinking back to a lecture I was listening to Gordon Guyatt talk, as we do it, a couple of years ago, and he said something that just opened my eyes. It was a real moment for me from an ABM point of view. And he said, if you can see the treatment effect, you don't need an RCT. And I liken that to the patient that comes into the trauma bay bleeding out of an artery, and you put your hand on the artery and it stops the bleeding.
Yeah.
No one is ever going to do an RCT about putting your hand on or not. And in fact, the BMJ themselves parodied RCTs when they printed the parachute article from Christmas, saying you need an RCT to assess the benefit of a parachute. So in my estimation, everything that Emil is saying is absolutely bang on. And then the other point of it is you can see the treatment effect. You see someone walk in pain and you see them leave the hospital shaking your hand. So
yeah, that's a great point. Excellent point.
Okay, fantastic. So I think we will move on to our Fast 5 stories. So our first story was requested by a listener who wonders if we should consider IM nailing as the first choice in treatment of proximal humerus fractures. Mo, what does the evidence say? Should IM nailing become the new gold standard?
Well, let me first say one thing. Professor Shevich, would you be willing to hang out with us for a bit longer? Because I know we brought you in as the core expert for the arthroplasty, but I know you like trauma, and I'm sure you have a thought on humeral shaft fractures and plating versus nailing. The argument here is that nails are the new gold standard.
First, I'd like to say I'd be delighted to stay. This is like...
Oh, great. Okay, so you don't have like a car appointment. You're not going for some sort of other thing. I want to make sure we don't want to take up your valuable time. You understand your time is valuable, right? And Brad's time, not valuable. Your time, hugely valuable. Yeah. We want to respect that, Just want to let you know. But thank you. Yeah, go ahead.
Well, fair enough. I think, here is actually an example of where we do need some evidence around non-operative versus operative treatment. I think one of the problems right now is that, we're doing RCTs looking at various methods of treatment. And I don't think we've as yet figured out whether or not, all patients or some patients benefit from surgical intervention. So I think the first thing that really needs to happen is figure out who actually would benefit from surgical intervention, then do the RCTs that show that treatment A is better than treatment B. Very difficult, if you're doing, a study and you're recruiting patients that are low demand, 90 years old, that pretty much don't need to use their arm for very much. If you're randomizing those patients to, a plate for versus a nail, like, are you actually going to show benefit of treatment A over treatment B? So I think step one is to try and figure out who actually benefits from surgical intervention. And then step two would be to do the randomized controlled trial looking at treatment A versus B in this area.
So Brad, let's assume from Dr. Shevich's point of view that you figure out, okay, that you're going to do a trial. Mm-hmm. Is nail versus plate? I mean, there have been meta-analyses done in the past, right? Meta-analyses in the past, I'm pretty sure suggested early on anyway, some decades ago, that plating remained to be a standard, right. Different than the lower extremity where nails have always been superior. Right. Has that tide changed in the humeral shaft?
Well, it seems there's been a fluctuance, as you said. There's been, you guys did the meta-analysis back when there were 3 RCTs, and then another RCT is added, and then it kind of fluctuates and changes. But there's, and the big crux of it is the union rates are the union rates any different? And it seems that some of the more recent meta-analysis suggest that there may be either equivalent union rates or slightly better, but with a nail, which is interesting because all of the previous stuff was favoring plates. But the one thing that is consistent is that the reoperation rates with nails for shoulder impingement and problems has been there over and above plates. And secondly, there's been an increase in the minimally invasive plate around the world in various places, and we don't even know what the benefit of that is yet. So I think the jury's still out. And to Emil's point, and to your point from earlier, all of the trials are still small. So we don't have that 3,000 patient trial. And secondly, if people figure out what fractures may benefit from a nail, they may be enrolling those patients, as Emil said. They may selectively be biasing.
Selection bias. Okay, cool.
I was just going to add, my initial comments, were more directed at the proximal humerus, which I had thought that we were discussing. If you're looking at the shaft, there's definitely a group of patients that would benefit from, fixation of a shaft fracture, trauma patients, floating elbows and so forth. I think in that patient population, I mean, traditionally, I think the plate has been the better mode of fixation. I think with, modern nailing techniques, changes in nail design, there may be an opportunity to relook at that. But I think if you look at the body of evidence in the shaft anyway, it would favor plate fixation. So I think it's probably something that, maybe needs relooking at. But if you look at all of the evidence, I would say a plate. I think in the proximal humerus, I think there's a real interest in using nails. But again, it gets back to the point that I was trying to make earlier, which is that in the proximal humerus, I think we still need to figure out, who actually benefits from surgery before we do the RCTs.
Thank you.
Okay, so on to our next story. In recent weeks, we've seen a drastic surge in COVID-19 cases happening across the Americas as well as around the world. Health officials have confirmed this is officially the fourth wave. Mo, what's causing this surge?
Yeah, I mean, again, I don't know, Brad and Emil, what your thoughts are with, this increase in number of cases. But I will give you a quote from the director of the United States Centers for Disease Control, who states, "This is becoming a pandemic of the unvaccinated. We are seeing outbreaks of cases in parts of the country that have low vaccination rates because unvaccinated people are at risk." I mean, it may be too simple, I think, to say that this is only a wave associated with non-vaccinated individuals. I do think there is what we're calling sort of the breakthrough infection approach to vaccines. The reality is not all vaccines are 100% effective. And in fact, when you look at a paper recently by Fahrenholt et al., 2021, they write an increase in COVID-19 vaccine breakthrough infections should be expected due to several reasons. First, no vaccines guarantee 100% of protection. And anywhere from if you look at the evidence, I think it's somewhere between 80% efficacy all the way up to 95, 96%. So somewhere between 4% and upwards of 20%, there are going to be breakthroughs. And actually, the more patients and individuals who are vaccinated, that number is going to keep rising, just because you're just going to see more of that happening. Secondly, we've been inundated with the Delta SARS-CoV-2 variant, right? And that variant is a particularly more difficult variant, much more infectious than any of the current circulating variants. And I think that also has led to increased infectivity. I think the R0 is pretty high for that. So that's another challenge. And we're going to see these breakthrough infections. I don't know, Emil, if you have any other thoughts on why we're seeing this fourth wave and how serious you think this fourth wave is going to be compared to others, for us in the healthcare side.
I think it probably will be serious. I think the breakthrough infection risk with the Delta variant, I think, is a significant risk. The other thing that concerns me, and I think we're still not totally understanding of this, is just waning immunity. So, there are a whole lot of people that were, vaccinated at the beginning of the year, January, February, March. It's 6 months, 7 months since that second dose vaccination. What's going to happen, over the next 4 or 5 months, get a year out from your second dose, will the vaccination be as effective against the Delta variant, in December as it was, 2 or 3 months after getting that second dose. So I think there's a number of factors that play, the ones that you mentioned. Then I worry about, waning immunity. And certainly you're seeing it, being an issue in, for example, immune compromised patients.
Yeah, no, thank you very much.
Brad, do you have anything else?
No, I agree with all those comments, and there's certainly multifactorial, but I think there's still a good argument to be getting vaccinated. So
great.
So on to our third story, which is our first Olympic injury story. Australia's Genevieve Gregson ruptured her right Achilles tendon in the women's 3,000 steeplechase final at the Tokyo Olympics. She sustained the injury when she fell coming off the final water jump and was unable to finish the race. In an interview, she shared that she had also been dealing with a chronic injury in her left Achilles, which she has been managing over the last few years. She plans to get surgery on both Achilles in an attempt to return to the track. So, Brad, what's your take on this?
Well, I mean, we've had lots of debates about Achilles ruptures and things like that. And if we're talking about pure Achilles tendon injuries, then we mentioned that on another podcast, that the actual incident or the risk ratio for re-rupture is decreased by 60% when you do surgery on these tendons. However, when you look at the absolute risks of rupture, they're very low. So 3.3% and 1.9% roughly in the non-operative group and the operative group. But, and in this case, it makes me think there is a subset of patients who have Achilles avulsions, and sometimes they occur bilaterally due to medications, due to some things like some antibiotics, or overuse syndromes and enthesopathies, so inflammation, chronic inflammation where the Achilles tendon attaches to the Achilles. And my own personal bias is that's a different entity, and you may be more inclined to fix them, especially with the bilaterals and especially if there's some predisposition. I don't know what you think about that, and if he did hear, he may not have heard me.
I didn't hear the last of that. Sorry, Brad.
See, I mean, I'm going to say something right here.
Sorry.
So here's the problem, Emil. Okay, the problem is, you see, Professor Petrodor just spoke for 10 minutes, and you didn't hear anything. I mean, this is a real problem for me, guys. Help me out here. This is a problem. My co-host is not being heard by eminent professors visiting us. Anyways, I'll raise it for you. So the question was on the issue of Achilles tendon rupture in athletes. Specifically, when you think about, sort of the issues associated with them, there may be a number of other inciting issues, like the type of medications they may be taking, other sort of predisposing conditions for why they get these injuries outside of the obviously mechanism that would be the injury and the, and in this particular,
especially when you're talking about bilateral disease.
Yeah, and these are bilateral Achilles tendon ruptures. So he was just looking to get your insight on that issue.
It's interesting. I mean, if you look at the evidence, I think, around Achilles tendon ruptures, there's not a lot of evidence that suggests that anything but non-operative treatment should be undertaken. I mean, you have an intervention that's effective, low risk, and the question is why do so many athletes have their Achilles tendon operated on? You see often a high level athlete in the NBA will have a tendon Achilles rupture, and immediately they're having surgery without even a trial of conservative treatment. So I guess the question is, why is that? And I'm not sure. I mean, at the end of the day, like when I look at the evidence, it would suggest that non-operative treatment is pretty effective. So I don't know.
So Brad, let me jump on that one. So in our very, very early meta-analysis that we did some years ago, I think actually Dr. Shemich is on that paper with us. But anyways, that's a side point. But I thought the point. It's funny. He heard me. You heard me, but he doesn't hear you. So, anyways, but the argument I was going to say is, I thought the whole argument for it was reoperation rates, right? It was a reoperation rates early on, right? So early aggressive operation and reoperation rates and earlier return to function. Is that still? I mean, for elite athlete, they do seem to preferentially get more aggressive treatment. Is that sort of just the paradigm, or is it warranted?
Yeah, I don't know. I agree with Emil about it, because there's still a certain proportion of those athletes, and this isn't very talked about, but we spoke about it in our article, that don't get back to play, even the ones that did get surgery. 17%, I thought it was, or 1 in 5. So there's still a certain proportion of professional athletes that don't get back to play, even with operative intervention. But that's never mentioned either. So I agree. I think there's some inconsistency. This particular one, though, makes me think, I wonder if there's some other predisposing. And again, if you have an avulsion off of the calc, that might be a little bit more of an indication in my books to actually fix it.
Brad, do you think the reoperation risk is less with surgery? I think that was always the traditional thinking, but
in the most recent meta-analysis that looked at both observational and experimental data, the absolute risk reduction was only 1.9%, like just barely 2%. So it was from 3.3 down to 1.9. So it's very, very, very small.
That's kind of my understanding. I mean, back in the day, years ago, we used to talk about like a huge difference in reoperation risk.
Like
between
10%.
Yeah,
Yeah.
exactly. Between operative and non-operative treatment. And I think the thinking on that has changed.
Yes, absolutely agree.
So moving on to our next story, which is our second Olympic injury story. Just 49 days after being hit by a car and breaking her collarbone while riding a bike during her training on Vancouver Island, Kasia Gruchala-Wysherski went on to win Canada's women's 8-boat rowing and officially became an Olympic champion. So Brad, is this a normal recovery rate for an injury like this?
Would you say 49 days?
49
6
days.
weeks roughly?
Mm-hmm.
My first response would be that's pretty quick.
Yeah.
To get going. However, very interestingly, the recent network meta-analysis by McKee and the group, and
Dr.
Emil,
Shemesh, right
yeah,
there. He's right there.
right
He's
there.
right in front of you. He's literally right in front of you.
And Dr. Shemesh. I mean, you identified the fact that, and I think yours was the first to actually identify the fact that at 6 weeks, the dash score in plated clavicles was better. I still think that 6 weeks is early, and I don't think that all bones are healed.
Mm-hmm.
But this is the first network meta-analysis right here that suggests that, in fact, at 6 weeks, a plate may make you better than non-operative management. There's lots of other factors, but I'd like to hear what Emil thinks about that.
I mean, I think if you look at like all of the evidence, I think there's no question that for a really significantly displaced clavicle fracture, the non-union rate is better with surgical intervention. I think everybody agrees on that. I think the issue really has been around function, and most of the work that's previously been published has talked about function at 1 and 2 years, and the studies have pretty much overall shown no difference. And that's really been a reason that people have sort of said that surgery may not help in terms of a functional outcome. But the nice thing in terms of the study that we just recently published is that we were seeing better function at 6 weeks in patients that had surgical intervention. And I think that kind of mirrors what we've seen, which is that individuals that are high performing athletes will get back to doing what it is that they need to do in short order if they have surgical treatment, whereas if they're treated non-operatively, the recovery is a lot longer. At a year, there's likely no difference, but at 6 weeks, there's definitely an advantage. And anecdotally, for example, there's a picture of Patrick Kane, hoisting the Stanley Cup, something like 6 or 7 weeks after he had his clavicle fracture fixed. So that is, very typical for high performing athletes that have operative intervention.
I agree completely. I mean, the thing is that it definitely helps the union rates for sure, and some of that early function. The big crux of the people who make the argument against is that, well, if you're going to heal, then there's no difference. And the big crux is really identifying and really stringently identifying who do we think is going to be that non-union group. And also, you're right, the other group is who can benefit by early range of early motion and early function. I would argue it's not just Olympic athletes, it's people who are in jobs that, require, the laboring jobs, et cetera, as well.
I think it's people that, are doing a lot of overhead activity, doing like a lot of lifting and so forth that need to get back to work. I think surgery actually really benefits that patient population.
Yeah.
I also wonder, Brian, I know it wasn't stated, I don't know, Abby, if it was either, but were there any other adjunctive treatments used? I mean, usually in elite athletes, the perception is let's be as aggressive as we possibly can, but also, provide adjunctive therapy. So there's things like ultrasound and, bone stimulation, things like that. I'm just curious if any of that stuff was used.
Yeah, it wasn't listed in the article, but that would definitely be interesting.
Okay,
Yeah.
All right.
Yeah. Okay, so moving on to our fifth and final story. In the first episode of OE Headlines, we discussed Conor McGregor's tibia and fibula fractures. In an update on one of his social media platforms, he mentioned that he was aware of multiple stress fractures before the fight. We received a number of questions from viewers after our first episode asking if the stress fractures leading to this injury could have been a result of steroid use. Brad, what are your thoughts on this?
I think that so steroid needs to be defined in this instance, and steroids are a couple of different types. So steroids like prednisone or glucocorticoids and things like that clearly have been associated with stress fractures. But those steroids are completely different than the anabolic steroid, such as the testosterones and dihydroandrostenediones and things. Those are anabolic in nature. And to my knowledge, and I'm going to ask Emil and Mo as well, but to my knowledge, those are building bone, and I don't know that there's a significant association with stress fractures. In fact, if you look at some animal models, there's a association with improving stress fractures using anabolic steroids. But we have to make a distinction between what steroid we're talking about. That's all.
All right, so that's it for today. We are officially out of time. I'd like to thank the OE community for joining us today, and a reminder to send any questions or topic ideas to headlines at myorthoevidence.com. Professor Bandari.
Distinguished Professor Bandari.
Distinguished Professor.
Thank you. Appreciate it.
Professor Petrazor, Professor Shevich. Thank you so much.
Professor. Love it. Well, thank you so much, Emil. Really appreciate you being on with us. Thanks you again, Brad.
Thank you all.
Thank you, Abby.
Thanks for having me.
See you again soon.
All right, sure.